Hello, everyone, and welcome to our module on heart failure basics. Let's start by talking about what we mean when we use the term heart failure. So, heart failure refers to an impaired ability of the heart to pump blood. And if you know that, then it's easy to remember that in terms of cardiac physiology, the hallmark of heart failure is a low cardiac output. This is what occurs in heart failure, and this is what drives all the signs and symptoms of heart failure. In order for you to have an image in your mind of what's going on in the body in a patient with heart failure, let's imagine a system where we have water flowing into a tank, and then that tank has the water being pumped out by a pump. Now let's imagine what would happen if this pump started to not work as well as it should. As you can imagine, the tank would start filling up with water, right? Because the pump is not as effective as it should be, so the pump can't drain the tank. And then if the pump got even worse, we'd get a situation like this where the tank is really overflowing with water because the pump is failing and very little water is being pushed forward. So if you have this image in your mind of this tank and water and a pump, then it's easy to understand heart failure. In heart failure, we're talking about the body. So the pump is the heart, and what the heart drains is the lungs and the body. So we have blood that is being drained by the heart, pumped out to the body, but the blood starts to back up when the pump is not working as well as it should. And where does it back up into? It backs up into the lungs and into the veins of the body. So as we'll see in heart failure, the problems that you get are, first of all, low forward flow, low cardiac output, like we talked about, and then blood backing up into the lungs and veins because those structures are not being drained by the heart as they should. A super important principle for you to understand in terms of heart failure is that when you have a failing chamber, like the left ventricle or the right ventricle, this will lead to increased pressures in that chamber. This is the hallmark of heart failure, is pressures that rise in the cardiac chamber. If the left ventricle isn't pumping blood like it should, it will start to fill up with blood. That blood will push more against the walls of the left ventricle, and the pressure inside the left ventricle will start to rise. So let's drill down on this concept of high pressure in the chambers of the heart in heart failure a little bit more. So when the left ventricle begins to fail in a patient with heart failure, this will raise the pressure in the left ventricle like I just talked about. But remember that pressure in the left ventricle goes from a low value of about 10 during diastole up to 120 when the left ventricle squeezes and contracts to push blood out. Well, this high number, the left ventricular systolic pressure, can actually be low in heart failure. That's because this number depends on the squeeze of the left ventricle, and in patients with heart failure, they have reduced contractility. But this pressure down here, the left ventricular pressure at the end of diastole, the LVEDP, this is always high when the left ventricle is failing. This is the hallmark of left heart failure. When you have left heart failure, less blood is pumped out of the left ventricular chamber, more is left behind. Those blood molecules push on the walls of the left ventricle at the end of diastole, and that creates more pressure. You can also get a high LVEDP when you have a very stiff ventricle, even if the contractility is okay, but it's stiff and can't fill. This is what happens in diastolic heart failure. That also leads to a high left ventricular end diastolic pressure. So it's super important that you understand that this pressure goes up when the left ventricular chamber is failing, not necessarily the systolic pressure. That's different and depends on contractility. Now remember that you have the left atrium, which sends blood into the left ventricle across the mitral valve in diastole. So at the end of diastole, whatever the pressure is here, it's going to be the same in the left atrium because the mitral valve is open. So anytime we have a rise in the LVEDP from heart failure, we will also see a rise in the left atrial pressure. Shown over here on the right side of the screen is Wigger's diagram, which I talk about in another video. But this is the end of diastole right here, and the left atrial pressure is the same as the pressure in the left ventricle at the end of diastole. So when the LVEDP rises, the left atrial pressure is also going to rise. And so this is another hallmark of heart failure of the left ventricle, high left atrial pressure. And remember that there are pulmonary capillaries which drain into the left atrium. And so when this left atrial pressure gets high, the pulmonary capillary pressure is also going to get high. And that's what causes two of the hallmark symptoms of heart failure, dyspnea and pulmonary edema. So let's drill down on this a little bit more. Shown on this slide is my own cartoon of a pulmonary capillary, and recall that blood drains from the pulmonary capillaries into the pulmonary veins and then the left atrium. So if you have left ventricular heart failure, then pressure in the left atrium will rise like we just discussed. That will raise the pulmonary capillary hydrostatic pressure. I talk about pulmonary capillary hydrostatic pressure in detail in the video on blood flow mechanics, but when this pressure rises, it drives fluid out of pulmonary capillaries and into the lung tissue. And so when you have heart failure on the left side and high left atrial pressure, you get high pulmonary capillary hydrostatic pressure, and this drives fluid out of capillaries into the lung tissues. And that's what causes pulmonary edema and dyspnea, which are two of the classic signs and symptoms in patients with heart failure. So now we understand that the pulmonary capillary hydrostatic pressure can rise in heart failure. Well, what about the vascular structures that come before the pulmonary capillaries? Well, flowing into the pulmonary capillaries is blood from the pulmonary artery. And flowing into the pulmonary artery is blood from the right ventricle. And flowing into the right ventricle is blood from the right atrium. And flowing into the right atrium is blood from the venous system in the body. So when this pressure starts to rise, all of these pressures are going to rise as well. So the high pulmonary capillary pressure leads to increased pulmonary artery pressure, and you see high pulmonary artery pressure in all patients with left-sided heart failure. The high PA pressure makes the right ventricular pressure go up, and then the high right ventricular pressure makes the right atrial pressure go up. And remember, the pressure in the right atrium is the same as the pressure in the central venous system. The veins in the right atrium are connected. There are no valves between those structures, so they always have the same pressure. So the bottom line here is that when you have failure of the left ventricle, that will go backwards, leading to high pressures in the venous system. And high pressures in the venous system of the body are what creates some of the other hallmarks of heart failure, like high jugular venous pressure, which you can see in the neck veins. We'll talk about this in a minute. And capillary leak from the systemic capillaries, not the pulmonary capillaries, the systemic capillaries. And this is what leads to pitting edema, another classic symptom of heart failure that we'll talk about in a minute. So it's very high yield to know that the high pressures in these chambers are what causes these symptoms, because that's what they're going to ask you about in your board exams. So now that we understand that when the left ventricle fails, we get all those high pressures that we just talked about, now we can move on and talk about how those high pressures lead to some of the signs and symptoms that you can see in heart failure patients. So some of the signs and symptoms of heart failure patients are related to the physiologic effects of lying flat, in other words, of the patient becoming supine. Anytime a person does this, there's more venous return to the heart. Basically, when you lie flat, you get a redistribution of blood volume, and more blood flows from the lower extremities and the splanchnic beds and the abdomen back towards the lungs. In normal individuals with a healthy heart, this has very little effect, and there won't be any signs or symptoms that arise from this. But if patients have impaired ventricles, they can't tolerate the increased blood return. And this leads to worsening of pulmonary congestion and breathing when lying flat. And that has to do with a lot of the signs and symptoms of heart failure. So now that we understand that, we can talk about the specific signs and symptoms of heart failure. And they're divided up into whether the signs and symptoms are related to problems with the left heart, meaning the left ventricle, or the right heart, meaning the right ventricle. When there's failure of the left ventricle, patients often get dyspnea on exertion, and this has to do with the high pressures in the left atrium and the pulmonary capillaries and the pulmonary edema. They can also get a symptom called paroxysmal nocturnal dyspnea. This is where patients suddenly wake up in the middle of the night short of breath. And this is because when they sleep, they lie flat. Sometimes they can tolerate it and fall asleep, but then over time they won't tolerate it and they'll wake up very short of breath. Patients can also develop orthopnea. This means shortness of breath when lying flat, and this has to do with what we talked about on the last slide. When you lie flat, there's more venous return, and this can make pulmonary congestion worse in heart failure patients. And so they often report this symptom of orthopnea where they can't breathe lying flat. In fact, some heart failure patients will tell you they like to sleep sitting up in a chair, and that's because their breathing is easier. When the right ventricle fails, you can see increased jugular venous pressure. We'll talk about this in a minute, but you can see distended neck veins because those veins are filled with blood from poor function of the right side of the heart. Also from right heart failure, you can get lower extremity edema. That's when pressure gets high in those systemic capillaries. And you can also sometimes get liver congestion and an enlarged liver. In rare cases, long-standing chronic right heart failure, you can get cirrhosis. And all these signs and symptoms I've shown on this slide here are sometimes referred to as symptoms of backward failure. That's because these symptoms aren't due to low cardiac output of blood moving out of the heart. They're due to blood backing up into the lungs and the veins and other structures in the body. So sometimes these are called symptoms of backward heart failure. Now let's talk a little bit about right heart failure. So the most common reason you get failure of the right heart to work is when the left heart is failing. Remember how we talked about before, you've got the left ventricle, but blood that enters the left ventricle comes through a number of structures from the right ventricle. So if the left ventricle isn't working and the pressures start to get high and blood builds up, that will go backwards and make the right ventricle start to fail. It will fill with blood and become dilated. So the most common reason that the right ventricle fails is because the left ventricle is failing too. However, there are some rare occasions where the right ventricle can fail in isolation. In other words, the left ventricle is totally healthy, but the right ventricle has a problem. In these patients, the left atrial pressure is normal because there's no issue on the left side of the heart, but the pressures are high in the pulmonary artery, the right ventricle, and the right atrium. This usually happens secondary to a lung process. So if patients have some form of lung disease, they develop pulmonary hypertension, which means high pressure in the pulmonary artery, and this causes the right ventricle to fail while the left ventricle stays normal. So you can see this in COPD and other forms of lung disease, and this is often called cor pulmonale because it's failure of the heart, coronary system, related to problems in the lung, the pulmonary system. In patients who have severe left ventricular failure and a very, very low cardiac output, they can develop signs and symptoms of what we call forward failure. These are symptoms that are related to very, very low cardiac output. So some of the things you can see are loss of appetite because the patient's gut isn't being perfused. This can lead to weight loss and cachexia. Underperfusion of the brain can cause confusion. The extremities can become cool because you're not pumping the warm blood out to the fingertips and the toes. And patients can have a very narrow pulse pressure. Pulse pressure is the difference between the systolic and diastolic pressure. So normal pulse pressure in a patient with a normal blood pressure of 120/80 would be 40. But in a patient with severe low flow heart failure, they could have a blood pressure of something like 80/60. In other words, the pulse pressure is only 20. And that's what happens when you have a very low cardiac output. You get a very tiny difference between the diastolic and systolic pressure. That's called a narrow pulse pressure. All of these things I've shown here are only seen with very low cardiac output in patients with advanced systolic heart failure. And you won't see any of these symptoms in diastolic heart failure. I talk about diastolic heart failure in another video, but in that form of heart failure, there's only a small reduction in the cardiac output, so you never get these symptoms. Any patient who presents with symptoms like these has a very, very low left ventricular ejection fraction. When you listen to the lungs of a patient with pulmonary edema from heart failure, the classic finding is the presence of rales. So rales are a popping sound or a crackling sound that you can hear when the patient inspires, and they are caused by fluid-filled alveoli that pop open on inspiration. You can see this in any form of pulmonary edema, whether it's from heart failure or some other cause of pulmonary edema like ARDS. When you do a chest x-ray, the classic finding is to see pulmonary congestion. If you look at the bottom of the screen, this is a normal chest x-ray where the lung fields are mostly black, and this is a person with pulmonary edema. They have this white, fluffy material in their lungs. That's fluid. That represents pulmonary edema. Now, you should be aware, however, that in clinical practice, sometimes the lungs in the chest x-ray will be clear in patients who have chronic heart failure, meaning the x-ray could be normal and you might not hear rales. And this is because over time, when patients have chronically high pressures in their lungs from heart failure, their lymphatics start to drain more fluid. So sometimes the lungs can be normal in patients with heart failure. But in board questions for step 1, if the patient has left ventricular failure, has left-sided heart failure, they're almost always going to tell you that the patient has rales, and they're almost always going to show you an x-ray that has pulmonary edema. We don't usually do biopsies of the lungs in patients with heart failure, but if you did, and you looked at some of their lung tissue under the microscope, the classic finding in a patient with heart failure and pulmonary edema is the presence of what are known as heart failure cells in the lung tissue. These heart failure cells are macrophages, and they're filled with hemosiderin, which is an iron-containing pigment, and this gives the macrophages a brown color. And the reason this happens is because when there's that high hydrostatic capillary pressure, it drives blood elements out of capillaries into lung tissue. That leads to some red cells and some hemoglobin in the lung tissue, and the iron is taken up by macrophages, and that creates the heart failure cells. And there's an example of some of them here on this slide, and you can search this up on Google and find lots of images of these heart failure cells in the lungs of patients who have heart failure. Earlier, we talked about how in patients with heart failure, the right atrial pressure gets high. And remember that the right atrium is connected to the venous system of the body, and there are no valves between these structures. So anytime the right atrial pressure goes up, you're going to get high pressure in the venous system of the body as a whole. And you can estimate the pressure in a patient's venous system by determining the jugular venous pressure on physical examination. The way you measure the jugular venous pressure is you have the patient lie back and then you raise their head about 30 to 45 degrees. Then you examine the neck, and there should be a point in the neck where you see the distended jugular veins and a little bouncing of the wave inside the jugular veins. The reason you see this bouncing is because of the A and V waves of the jugular venous pressure tracing, and I talk about that in another video. But to measure a patient's jugular venous pressure, you determine this point at which you see the double bounce of the A and the V waves, and you determine how many centimeters it is above the sternum. So let's say, for example, in this man here, it was 3 centimeters above the sternum. You then add 5 centimeters because that's how high the sternum is above the right atrium, and that gives you the jugular venous pressure. A normal jugular venous pressure is about 6 to 8 centimeters of water. In patients who have heart failure, it can be 10 or 12 or even higher. And once again, the way you do this is by positioning the patient like this, and then looking for the height of the double bounce in the jugular vein caused by those A and V waves. Another finding on physical exam that indicates high pressure in the venous system is the presence of hepatojugular reflux. The way you identify hepatojugular reflux on physical exam is you position the patient like this, just like we talked about on the last slide, and then you press on the abdomen with your hands, usually just below the liver. This will cause that double bounce in the neck to rise a few centimeters. Normally, it should only rise about 1 to 3 centimeters, but if patients have failure of the right heart and high venous pressures, then the rise will be greater than 1 to 3 centimeters. And so when you identify this, it is said that the patient has the presence of hepatojugular reflux, and that's another classic finding of heart failure indicating high pressure in the venous system. Another sign of heart failure that you see in patients who have right heart failure is the presence of lower extremity pitting edema. Edema means swelling of the lower extremities, and pitting edema means that when you press on the patient's lower extremities with your fingers, like this person is doing here, and then remove your fingers, it will leave a pit behind. And the reason the pit stays behind is because the tissue in the lower extremities is filled with fluid. As we talked about earlier, the reason this finding occurs in patients with heart failure is because they have elevated capillary hydrostatic pressure, and it's high yield to know that. They have elevated hydrostatic pressure in the systemic capillaries. It's driving fluid out into the tissues, and then gravity is pulling the fluid down to the lower extremities when the patient stands. And therefore, when you examine their lower extremities, you can find evidence of pitting edema. Now, there are other causes of pitting edema besides heart failure, but in a patient who has heart failure, this is a classic finding. There are some abnormal heart sounds that you can hear with the stethoscope in patients with heart failure. I talk about these in detail in the video on heart sounds, but by way of brief review, the third heart sound, the S3, occurs in patients who have high left atrial pressure, so patients with left heart failure. And then the S4, the fourth heart sound, is associated with a stiff left ventricle. You often see this in patients who have diastolic heart failure. So remember that systole occurs between the two normal heart sounds, S1 and S2. The S3 is a diastolic heart sound. It occurs early in diastole, just after S2. The S4 is a late diastolic heart sound. It occurs late in diastole, just before the next S1. And then besides the abnormal heart sounds, if the left ventricle is dilated, you can have displacement of the apical impulse. Normally, when you feel for the point of maximal impulse on the patient's chest, it should be in the fifth intercostal space in the mid-clavicular line, but it can move laterally in patients who have an enlarged left ventricle and an enlarged heart from left ventricular heart failure. Okay, now let's talk about some stuff that is super high yield for step 1, and this is the pathophysiology underlying patients who have heart failure. So like I told you earlier, all forms of heart failure lead to a decrease in the cardiac output. And when cardiac output falls, the blood pressure gets lower. Remember, your blood pressure is determined by the product of your cardiac output and your total peripheral resistance. And so when the blood pressure gets low from low cardiac output, that's going to activate a response from the body. Specifically, it's going to activate two physiologic systems. First of all, the sympathetic nervous system, and secondly, the renin-angiotensin-aldosterone system. So in patients who have heart failure, they always have increased activity of their sympathetic system, and all their RAS hormone levels rise because of activation of the RAS. And both of these systems lead to two key effects that occur in patients with heart failure. First of all, they get vasoconstriction of peripheral arterioles. This raises the peripheral vascular resistance. The body is trying to compensate for the low cardiac output by increasing the TPR to try and maintain blood pressure. And then the other thing that the sympathetic system and the RAS do is cause retention of sodium in water, and this is due to effects in the kidneys. So let me emphasize the point I just made on the last slide about total peripheral resistance, because this is very high yield to understand for step one. So when the cardiac output falls in patients with heart failure, this will cause vasoconstriction of peripheral arterioles. This is mediated through angiotensin II from the RAS, and it's also mediated by the sympathetic nervous system. This will raise the TPR. So it's very important to understand that patients in the setting of acute heart failure always have high total peripheral resistance. Now, your blood pressure is a product of the combination of cardiac output and TPR. So the blood pressure can be high or low. In fact, it's often high in heart failure because people are stressed from difficulty breathing and their sympathetic system is very active and their TPR gets very high. But it can also be low. And whether the blood pressure is high, normal, or low depends on the combination of changes to the cardiac output and TPR. But no matter what the blood pressure does, the TPR will always be high in patients who have heart failure. And now let's talk about the sodium and water retention that occurs in heart failure. So when the cardiac output falls, this leads to a decrease in the effective circulating volume. And I talk in detail about the concept of effective circulating volume in videos in the renal section. But when that volume gets low, the RAS becomes active, the sympathetic nervous system becomes active, and levels of ADH rise. And all of these things combine to cause the kidneys to hold on to salt and water, and that leads to an increase in total body water. So it's very high yield to know that patients in heart failure have high total body water, and you can see that in physical exam. There's edema in their lungs, there's edema in their legs, their neck veins are distended. This is all evidence of retaining salt and water caused by the mechanism shown on this slide. Besides the hormones involved in the RAS system like angiotensin II, there are some other hormones whose levels rise in heart failure, and one of those is atrial natriuretic peptide, or ANP. So when the atria in a patient with heart failure are filled with blood volume and the pressure gets high, the atria cells get stretched, and when they're stretched, they release ANP. ANP has effects that are opposite of the RAS system. So where the RAS system causes vasoconstriction, ANP causes vasodilation, which tends to lower TPR. ANP also constricts renal efferent arterioles, so it constricts these, and it dilates the afferent arterioles, and this will cause more blood to be filtered in the glomeruli, and it will cause more urine to be made so that there is a diuresis. And so the effects of ANP are opposite of the RAS system. The whole ANP system probably evolved to counteract the RAS system when RAS is overactive. But unfortunately, in heart failure patients, the natural ANP system isn't strong enough to overcome the RAS. And so you still have RAS activation, and you see all the effects of the RAS like vasoconstriction and retention of salt and water. ANP offsets some of them through these mechanisms, but it can't reverse the effects totally and prevent the clinical syndrome of heart failure from developing. Besides ANP, which is released by atrial myocytes, there's another protein called BNP, which stands for brain natriuretic peptide. It gets its name because it was first described in the brain, even though it's also made by cells in the heart. So whereas the atrial myocytes release ANP, the ventricular myocytes release BNP. But both of these hormones, ANP and BNP, have their levels rise when there's volume pressure overload in the chambers of the heart, and both of them do the same thing. They counter the effects of the RAS. Neither of them are effective enough naturally to overcome what the RAS is doing in heart failure, but they try to do that. That's their role in the body. And we sometimes measure the BNP level for diagnosis of heart failure in a patient with dyspnea. The patient has dyspnea and you're not sure whether it's caused by lung disease or deconditioning or heart failure. You can measure the BNP level, and if it's high, that suggests heart failure. If it's low, it suggests some other cause. So that's a nice segue into how we make the diagnosis of heart failure. So the most common way the diagnosis is made clinically is when the patient has typical signs and symptoms, we say that they have heart failure. So when a patient who has shortness of breath and rails on their lung exam and elevated jugular venous pressure in the neck and lower extremity edema, that's enough that we can say they have heart failure. And as I mentioned on the last slide, you can measure a BNP level, and an elevated BNP level supports the diagnosis, but it's not perfectly specific, so you still need to have signs and symptoms. If you really want to know if someone has heart failure, though, the gold standard is a heart catheterization. We rarely do this because it's an invasive procedure, but this involves threading a catheter into the chambers of the heart, like what's shown on the slide here, and you can measure the wedge pressure in the pulmonary capillaries, and this is basically equal to the LVEDP, so if that's increased, It tells you the patient has left heart congestion and failure. You can also use the heart catheterization to measure the right atrial and right ventricular end diastolic pressure. And when these are increased, it tells you the patient has right heart congestion or failure. But this isn't often done. And as I said, clinically, what you will most often see is typical signs and symptoms being used to make the diagnosis of heart failure. And that concludes our video on heart failure basics.